Evening, guys. If anyone is on, can they just send me out a little message just to make sure that the audio and the visuals are okay? We're going to get into content in just a couple of minutes. So if someone is watching, if they can just confirm they can hear and see me okay and that the live stream is working, we'll get underway in just a couple of minutes. Evening, gents. Thank you. Thank you. Okay, folks. Well, welcome to our monthly live Q&A session. So this is an opportunity for members of our channel to ask me a question, and we can dive into anything related to your prostate. I've got several questions to go through today. If you've got comments or things you'd like to know more in depth when we're going through one of our members' questions, please just reach out in the chat and let me know what you think or what's going on as we go through things. Okay, so let's start with the first question, which came from one of our members following a green light laser prostatectomy, but I'm going to answer this question in a more generic fashion. I should say right at the very outset that the answers that I can give to specific questions here today really will be dealt with in a fairly generic fashion. Obviously, this does not constitute specific medical advice for your situation. I don't know your specific situation, and everyone has their own individual nuance or characteristics, and therefore I encourage everyone to use this as general information only, and please do discuss matters more specifically with your local urologist. Okay, so first question really is, someone has had a TURP or a green light laser prostatectomy to manage their urinary symptoms that were related to an enlarged prostate. That gentleman had a catheter after the procedure. It was removed and he couldn't pee. So the question was, why can men not pee after they have a BPH procedure? So let me take a backward step really to explain what's going on. So BPH is the benign enlargement to someone's prostate. As many of you may be aware, the prostate, it's shaped a bit like a donut. It sits underneath the bladder and there's a central tube through which we pee. As we get older, the prostate grows, i.e. the donut, and that causes compression or obstruction to the bladder. Now, a TURP, the TURPS operation, colloquially known as the rebore operation, or certainly at the prostate clinic here in Queensland, that's been superseded for a long time now by a green light laser prostatectomy. But in essence, both of these treatments are there to try to remove the overgrown tissue that's causing the obstruction. Now, in the evolution of this disease, as the prostate grows and causes progressive obstruction to the bladder, the response in the bladder wall is that it needs to squeeze harder, it needs to generate more pressure to try and force urine beyond the obstruction. And when that happens every pee for several years, the muscle in the bladder wall gets thicker and stiffer and can cause some urinary issues in and of itself. They can, in essence, be going more frequently, rushing to the toilet, or getting up at night multiple times to go and pee. Now, if the situation is left unchecked and there is progression of obstruction to the bladder, then what can happen is that men poorly empty their bladder with time and, in essence, begin to retain more and more urine. And when you retain more and more urine, the bladder itself becomes more dilated, and there can be damage to the detrusor muscle. The detrusor muscle is the muscle in the bladder wall. And when that becomes damaged, it doesn't function properly. And we end up in this vicious cycle, really, whereby there can be a greater volume of urine that's left behind inside the bladder after every pee. Now, when someone has surgery, the aim is obviously to remove the obstruction. So we remove the obstructing tissue. For the majority of people who have a green light laser, the catheter is left in place, usually overnight, but following a TURP, it's standard practice to leave a catheter in, usually for a couple of days. Sometimes, if men have what we call chronic urinary obstruction, then their bladder volume is overstretched for a long period of time and they're retaining far too much urine. In that context, even when we remove the obstructive tissue, if we leave a catheter only for a short period of time, sometimes men just don't pee and empty their bladder properly because of detrusor muscle damage. So the detrusor is the pump and the obstruction is related to the prostate. And if the pump doesn't work properly, then we can have issues with retention. Sometimes when we're doing a particular procedure, if the prostate is larger in size, if it's more complex in its shape, that procedure can proceed for a longer period of time also. And with longer duration procedures, there is more stretch in the bladder wall related to irrigating fluid. What I mean by that is, in order for us to see what we're doing when we operate, we have irrigating fluid, which can be saline or sometimes glycine if someone's having what's called a monopolar TURP. But basically, there is fluid that we use to try and improve our visualization. And if the bladder is kept full for a prolonged period of time, that can also slow down the recovery and the ability of a bladder to empty. So, long story short, the reasons really why, even though after someone's had a BPH procedure such as a TURP or a green light laser prostatectomy, why they may not pee when we take the catheter out is either that man has been exposed to chronic obstruction with chronic retention of urine, or alternatively, potentially the bladder may just be a bit stunned related to the procedure itself. For the majority of men, this is managed with an additional period of catheterization. That can be anywhere from a few days out to a week or two, depending on that individual's particular profile. And that's really why this is not specific advice to someone, because everyone's situation is very much unique to themselves. Okay. Let me just have a quick look at the comments here. But that, in essence, is why some men don't pee after they have a prostate treatment for BPH. Okay, now I have a question here from John McCall. And John had been making some inquiries. John, I don't know if you're watching with us this evening. If you are, good evening to wherever you are on the planet. John had a question with regards, in essence, side effects related to a prostate biopsy. Now, a prostate biopsy, as many of you are aware, still in 2025 is the cornerstone of how we achieve a prostate cancer diagnosis. You know, at the entry level, obviously we have a PSA test, and there are nuances to the PSA test that raises our suspicion. Beyond that, we have MRI scans, multi-parametric MRI scans using a 3T MRI, which really has revolutionized how we screen and detect prostate cancer over the last 10 to 15 years. Beyond an MRI scan, in some centers, we use PSMA PET scan, which can be used either as an adjunct to the MRI scan, or more specifically and more commonly, the PET scan can be used as a staging tool if someone has a diagnosis of prostate cancer and we're trying to work out the extent of their disease before we discuss treatment strategies. So following potentially a lesion that's detected on an MRI scan, that gentleman may be offered a biopsy. And I've discussed on this channel multiple times previously the different ways that biopsies can be done depending on your geographical location. Historically, it was done in a transrectal fashion. Certainly in Australia over the last decade, the standard approach really has been to perform this biopsy in a transperineal or through the skin fashion. Following on from that biopsy, one of the big advantages to a transperineal biopsy really is a significant reduction in the probability of a post-biopsy infection. And that really is the big advantage. That being said, after a biopsy, very common for men to notice blood, certainly in their urine, blood in their ejaculate fluid, and blood in their stool. I say to the majority of men that blood in your urine usually settles down pretty quickly, as it does within their stool. And blood in ejaculate fluid, it will depend very much on size of prostate, number of tissue samples that are actually taken. But for the majority of men, it settles within a couple of weeks, but it's not uncommon to still see discoloration in ejaculatory fluid for the better part of 4 to 6 weeks following a biopsy. What is not normal is for men to have a temperature or a fever after a biopsy. And certainly if someone were to experience that, then that is a cause for concern and needs to be evaluated with your healthcare provider ASAP. Okay, so that was a question about really side effects that can happen pursuant to a biopsy and how long we can expect them to be present for. Okay. Any updates on that? I've got some other questions coming through. Give me just one moment. Okay, was almost about to run out of power there, gents. Sorry for that. Okay. Next question that I have relates to complications following BPH treatments, in particular, incontinence. So urinary incontinence after someone has a BPH treatment. And if I put these in a couple of broad categories here, we have minimally invasive treatments. So that includes things like Resume, Urolift, iTind, or cavitating surgery, traditionally a TURP. More recently, that's been superseded by various forms of laser prostatectomy, such as a green light or a HOLEP. For those men who have massive BPH, as defined as very, very big prostates, these men can be managed with a robotic simple prostatectomy. So incontinence, if I start there, incontinence obviously is defined as the involuntary loss of urine. And following surgery, following BPH surgery, we can see urinary incontinence. There are two key types of urinary incontinence that we do see. One is called urge and the other one is called stress. So urge incontinence relates to that situation whereby a man can feel busting to go to the toilet. You feel like you're in a real hurry to get there suddenly, and that urine comes away before you make it to the toilet. Now, this form of incontinence is far more common than stress incontinence. And urge incontinence really is related to changes in the bladder. As I described at the very start of this live event, the evolution of BPH, whereby it causes progressive obstruction to the bladder wall and thickening of the bladder wall that manifests as frequency, urgency, and getting up at night. Now, when we unblock a chronically obstructed system, it's not uncommon for men to experience some heightening in that urgency that for the majority of people is relatively short-lived. So we unblock this system really that's been under duress for a period of time. And the process of unblocking that bladder, we can see more intense urgency, frequency, and nocturia, or getting up at night to pee. Now, some of the key ways to manage this really are to have a look at fluid load and also the characteristics of various fluids that you are taking on board. I certainly advise my patients at the prostate clinic to be mindful of the amount of caffeine that they're taking on board. So look at tea and coffee, look at how much water in general you're consuming in the day, and be mindful of alcohol as well. Alcohol obviously is a fluid load. It's a powerful diuretic as well and an irritant of the bladder, and can cause men to experience more heightened frequency and urgency. So just be mindful of that if you're going through the recovery phase following a BPH procedure. I should mention that urgency or urgent continence, when it does happen, almost always settles down. Sometimes it may require some medications to facilitate the bladder softening, but in essence, urgency with urgent continence always settles down. Important to note, though, that in some men who have diabetes that are on certain diabetic medications, these drugs can pull sugar into the urine, and it can make the postoperative period a little bit challenging for these men. The other type of incontinence is stress incontinence. And conceptually, you may have heard me discuss that the prostate's a bit like a donut. It sits between the base of the bladder and the pelvic floor. And when we're performing procedures to remove the overgrown component of a prostate, it is possible for there to be some bruising or damage to the muscle that keeps a man dry. The way that this can manifest is that if a man coughs or sneezes or twists or exerts himself in some way, it's possible that there can be additional pressure on the bladder that can cause some leakage of urine or a squirt of urine to come through. The way that we manage this really is with pelvic floor physiotherapy that can strengthen that pelvic floor and rectify that situation. Excuse me. So incontinence after BPH surgery, yes, it can happen. Urge incontinence is far more common than stress incontinence, but there are those two key aspects to be aware of. Excuse me. Does that answer that question, or does anyone have any points with that regard? Bear with me while I just read some of these comments. Got a couple of PSA questions in there. All right. Okay. I will. Okay. Well, I might move to the PSA question. I did have a question about PSA levels and what they are indicative of. As I'm sure many of you are aware, the PSA test is our blood test that screens for prostate cancer. It stands for prostatic specific antigen. It's a chemical made by the prostate. It's found in small amounts in the bloodstream, and it's also found in a man's ejaculate fluid. And its role physiologically is to liquefy semen and increase the chance of conception. We use the test, as I said, to screen for cancer. One of the challenges that we have with this test is it can go up if your prostate's big, if your prostate's inflamed or irritated. and also can go up, obviously, if someone has cancer. Now, the metric where a PSA becomes significant has really evolved since a PSA test was used in clinical practice in the early 90s. So, it's been around for 30 plus years. Originally, it was to be used as a disease monitoring tool following a diagnosis of prostate cancer, but quickly evolved into being a screening test. Now, historically, a PSA less than 10 was considered normal, and that figure has gradually been reduced with time. Here in Australia, up until around 3 years ago, if a man was in his 60s, we accepted a level that was less than 4.5 as normal, with a median, or the most common value, being 1.2. Since that time, for men less than the age of 70, really the standard, the normalized value now is less than 3, and the median is still at 1.2. So if a man has a PSA above 3 in his 60s, it's really an indication for further evaluation. At that point, we start looking at MRI scanning to assess the anatomy within someone's prostate. If someone is in their 70s, the threshold value that we utilize is 5.5. So there is this age-adjusted value that is accepted, and really that reflects the probability of BPH, or the benign enlargement, that is more common as we progress through life, and as the prostate grows, it will produce more PSA. Really, there is definitely a correlation between PSA value and probability of prostate cancer. And the higher the PSA, the greater the risk that someone does have prostate cancer. Now, in my clinical practice, the highest PSA that I have ever seen that was associated with benign disease was a PSA of 100. Now, it should be made abundantly clear that that gentleman was very unwell. He was in hospital. He had a high temperature, an infection in his urinary tract, and that's why his PSA was so high. He subsequently had BPH surgery. He actually had a green light laser prostatectomy, and his subsequent PSA in the months after treatment had declined to less than 1. That being said, that is the rarity rather than the rule. In terms of the range, the highest PSA that I've seen is a PSA of 9,999, and that was a gentleman that I saw in one of the first months of my clinical practice almost 20 years ago. Needless to say, with a PSA that high, that gentleman did have metastatic prostate cancer with deposits in lymph nodes and extensive deposits throughout his bony skeleton. So with PSA, when we're looking at PSAs that are in the hundreds or in the thousands, these PSA values correlate very strongly with a prostate cancer diagnosis and probably extension of disease further afield. So those men with such high PSAs are most likely to have metastatic prostate cancer. Certainly, if you did have a PSA that was high, using the metrics that I've mentioned, please make sure you do talk to your local doctor or your urologist about where you go moving forward. Okay, so as an extension from that question, looking at PSA testing following treatment. So let's assume for a second someone has a radical prostatectomy, so they have surgery to remove their prostate, and we're undergoing PSA testing. The first time that we do the PSA test is usually around 10 to 12 weeks after surgery. The reason why we give it time from surgery to doing the first PSA test is that it does take time for your body to wash through all of that PSA. And if you have a PSA within a week or two of having a radical prostatectomy, then you'll still have a PSA value. At the prostate clinic, I usually leave it around 10, 11, 12 weeks following surgery, and that gives us a set point. So in essence, no prostate, your PSA should be 0. And as long as the PSA is 0, we continue monitoring. The monitoring process is done at the prostate clinic 3 monthly for the first year. And then it's done 6 monthly from year 2 to year 5, and then annually thereafter. So crudely speaking, the closer we are to surgery, the more commonly or the more frequently the PSA test is done. And then we start pushing the can down the road as we see and get reassurance that the PSA remains undetectable. Now, we can see different distributions of PSA recurrence following surgery. And a lot of guys wonder why we need to do the PSA test when the prostate's removed, but in essence, it's our quality assurance marker. And if the PSA goes up after surgery, it tells us that we do have a cancer cell or cancer cells that are beginning to become active and producing PSA. So when we remove a prostate, we look at the final pathology to try and get a prediction about whether or not we think someone is more prone to local recurrence or distant recurrence. And those men that are more likely to develop local recurrence are those men, for example, who have cancer that has extended beyond the shell of the prostate, or potentially extended up to the seminal vesicle, or potentially up to the resection margin. So if we see those characteristics, those men are at a greater risk of local recurrence, and the PSA can increase gradually and slowly and progressively with time in that context. If, however, someone has higher grade disease, so for example, a Gleason 8, 9, or 10, and that cancer is contained, then there are no risk factors for local recurrence. And that man, if he were to see a change in his PSA with time, that is more likely to be micrometastatic. And that actually can happen several years down the track. It doesn't necessarily happen very close to the time of his surgery. Now, what we do, the way that we manage those two different scenarios is actually very different. So if we think someone is more likely to have local recurrence on the basis of their PSA evolution and also on their final pathological characteristics, then these men are candidates for a discussion with regards adding on radiation therapy, which is called salvage radiotherapy. If we think that a man has a low probability of local recurrence, then we tend to watch those men. We watch their PSA and we wait until it gets to a threshold. When that PSA gets to a threshold, then we look at restaging a man's disease with a contemporary PET scan, a PSMA PET scan, to see if we can identify exactly where that man's recurrence may be. Okay, I hope that answers the PSA question. I think that answers the PSA question. Okay, let me move on now. I had an interesting question looking at the pathology, i.e., the different types of prostate cancer that we can see. And I had a question about ductal carcinoma. Without getting overly technical with this question, the majority of prostate cancers that we see are something called adenocarcinomas. It's the most adenocarcinomas is the most common type of prostate cancer that we see. A rarer variant is this entity called ductal carcinoma, and you may see it on your pathology reports if you are privy to them, if you've had either a biopsy or you have had prostate surgery. Now, the significance of this, I try and describe this to my patients. When we look at either the biopsy or we're looking at the final pathology assessment when someone's had their prostate removed, in essence, what we're doing is we're having a look at someone's blueprint of their cancer, and we're trying to work out, really on a scale of not very aggressive to very aggressive, where an individual's cancer sits. And we're trying to ascertain A, the probability of long-term cure, B, what's the probability of recurrence, and if we think they're likely to recur, do we think that's likely to happen locally, or do we think that's more likely to happen in a metastatic or in a distant fashion? Ductal carcinoma, the easiest way to think about it is that it is the technical term is it's an adverse prognostic characteristic, i.e. it's a sign of aggression. So yes, we look at things like Gleason score, we look at volume of cancer, we also look at ductal component. Now, you may have heard that some prostate cancers actually don't produce a great deal of PSA. And so these are the men that we diagnose that actually may have a normal PSA test, but they may have an abnormal examination of their prostate, or they may have a lesion on an MRI scan despite having a normal PSA. The other challenge with men who have a larger component of ductal cancer is that when we stage these men, so when we do a PSMA PET scan, to try and determine if someone has local cancer or cancer that is spread, when there is a larger component of ductal cancer, the probability that we have expression of the PSA on the PSMA, sorry, on the PSMA PET scan is less. So they can have this scan and we don't see anything. It doesn't mean it's not there. It's just mean that their cancer is not expressing that particular antigen, and that can relate to a higher proportion of ductal cancer being present. Oh, that's not too technical for you guys, but the characteristics that we look for, and if you've had a biopsy or if you've had prostate surgery, the keys that you want to look at are: what was your final Gleason score? What's the volume of disease? So on a biopsy, how many cores are involved with cancer? And of those cores that have cancer in them, what's the percentage of a core that is replaced with cancer? If, however, you've had your prostate removed, you want to know really what the volume of cancer within your prostate is. Is it contained? Has it extended to the shell? Is there extension to the vesicle? The other aspects that are important are whether or not there is invasion of lymphatic channels, little nerves within the prostate, or is there invasion into blood vessels also. All of these things are metrics for us to try and work out if someone has more aggressive prostate cancer. Okay, let me just have a look here. Any other questions? Okay, so looking at, so if I just finish up on that PSA question, and this is from a generic standpoint, the kind of line in the sand that we accept with a PSA after someone's had their prostate removed is a PSA that's stable and less than 0.2. And the reason why we use that metric of 0.2 is sometimes there can be benign glands left in the base of the bladder, or actually in the urethra, the outlet pipe of the bladder, that can still secrete tiny amounts of PSA and can give men a PSA reading even though they don't have a prostate. And so sometimes I will see, when we're monitoring men's PSAs for a long period of time, that they can have trace PSA. That PSA doesn't evolve, it doesn't increase, it just kind of grumbles along at a very low level. And as long as that's the case, no problem. If, however, the PSA continues to increase, that's when we know we're dealing with recurrent prostate cancer. So recurrent prostate cancer, the PSA will continue to increase with time. And then if we're faced with that situation, we go back to the final pathology again to try and work out, is it more likely local or is it more likely to be distant or further afield? Okay. Any other queries, gentlemen? Any other queries? I think we've been through lots of that. I've got a question there from Powderworks, just put in the chat. You've been on combination therapy for 18 months, no improvement. Which procedure? As I said, I'm sorry, I cannot give specific advice in this forum. That really is a discussion for you to have with your local urologist. You may be aware, if you've looked at content from the channel, that there are a whole host of treatments out there for men's urinary symptoms. And certainly, if there's failure following maximal medical therapy, then the next step really is to have a discussion about your specific nuance, your situation, um, with your urologist for clarification, really. Okay, anything else people want to know? They were the topics that I wanted to get through tonight. Does anyone have any comment that they'd like to make? Evening, Wayne. How are you? Wayne, have you got a comment or a question, Wayne, that pertains to some of our discussion? Happy to go through it. Okay. Well, gents, let me know, please, if you enjoy this forum of Q&A. Our vision is that we have and continue to have a monthly Q&A. It will be the last Thursday of every month. It'll start at 7:30 Australian Eastern Standard Time, and members of the channel, throw your questions at me and we will go through your questions, and subscribers are most welcome to come and join and learn from our discussion. But if you have a specific question, join the channel, get your question to us in plenty of time, and I will make sure that question is answered. Quick one here, Ron, about Resume. Well, Resume, for those that are unaware, Resume is a minimally invasive treatment for the management of urinary symptoms related to BPH. The big potential advantage to Resume over cavitating surgery is a far lower risk of ejaculatory changes. It can still happen, but it's far less common than it is with cavitating surgery. I counsel all my patients that following cavitating surgery, it is to be expected. So cavitating surgery are things like a green light, a TURP, or a robotic simple prostatectomy. The minimally invasive treatments are things like Urolift, Resume, or more recently, iTind. Um, Basically, on a spectrum of minimally invasive to maximally invasive, we can influence the magnitude of improvement that we can expect to see from a urinary function point of view. But what we're trying to achieve with these more minimally invasive treatment options is a big reduction in the probability of retrograde ejaculation. The challenge with any treatment is that there is no guarantee that we can affect a perfect outcome, and there are people that have Resume that can have retrograde ejaculation or anejaculation, and that from a technical point of view can be more common in those men if they've got a median lobe, a projection of prostate tissue that grows into the bladder and causes obstruction. Anytime we interfere or treat the bladder neck, there is always a risk of retrograde ejaculation. And so treatment becomes a balance between unobstructing someone, but trying to limit sexual function side effects. All right, people. I think that might be a wrap for tonight. I hope that answered your questions. Let me know if you if this is beneficial. If you'd like to do more of these sessions, as I've said, the aim is to make this, or to continue this session, last Thursday every month, 7:30 Australian Standard Time. Until the next time, people, take care.